Erysipelas is an acute bacterial skin infection involving the superficial dermis and the lymphatics, characterized by the sharply demarcated raised erythematous and the tender skin lesion. Causative organism Group A Streptococcus. Group Streptococcus pyogenes is the most common pathogen, less commonly Group B, C, or the G Streptococcus. Predisposing factors skin barrier disruption, trauma, ulcer schema, lymphedema, or the venous stasis, immunosuppression, diabetes, HIV, obesity, pathophysiology, entry of the streptococcus through breaks in the skin, bacteria proliferation, release of toxin, inflammatory mediator, marked dermal inflammation, and the lymphangitis. Clinical features, general symptom, sudden onset of the fever, chills, and malaise. Lymphadenopathy may be present. Local symptom, painful, bright red, and the swollen skin lesion. Lesion is raised and indurated and has sharply demarcated borders. Commonly affects the face or the lower limb. Overlying skin may feel with the warmth and the tender. Vesicles of blood may form in the severe cases. Red or orange appearance due to the skin edema. Cellulitis, deeper infection involving the subcutaneous tissue, less well demarcated and no raised border. Contact dermatitis, non-infectious, associated with the viruses and the history of allergens. Necrotizing fasciitis, rapidly progressive, pain out of portion to the skin findings, associated with the systemic toxicity. DVD, no erythema, presence with urinary leg swelling and the pain. Diagnosis, clinical diagnosis, based on the characteristic presentation. Laboratory test, CBC, elevated by blood cell counter, CRP-ESR, elevated inflammatory marker. Microbiology, blood culture. In the severe cases of the immunocompromised patient, skin swab or the aspirate rarely useful due to the superficial nature. Imaging if needed, ultrasound or MRI to rule out the deep infection like abscess or the necrotizing fasciitis. Management, general measure, rest and elevate the affected limb to reduce edema, maintain the hydration, treat the underlying condition, lymphedema and the diabetes. Antibiotics, first line therapy, penicillin, oral or the intravenous for the severe cases. Alternatives, amoxicillin or the cephalexin for the mild cases. Clindamycin or the penicillin, allergic patients. Severe infections or the hospitalization, IV ceftriaxone, ceftriaxone or the flucloxacillin. Add vancomycin if MRSA is suspected. Supportive care. Analgesics for the pain relief, antipyretics for the fever. Prevention addresses the skin plaque or the chronic condition. Prophylactic antibiotics for the recurrent erysipelas. Complication. Recurrent erysipelas leading to the chronic lymphedema, abscess formation, deep tissue infection, cellulitis, necrotizing fasciitis, systemic complication like the septicemia. Prognosis excellent with the prompt treatment. Delayed treatment can result in the complications of the recurrence. Erysipelas is a superficial bacterial infection of the dermis caused by the Streptococcus pyogenes. Key features, sharply demarcated erythematous raised skin lesion, common face and lower limb. Systemic symptoms, fever, chills, and the lymphadenopathy. Differential diagnosis includes cellulitis, contact dermatitis, necrotizing fasciitis. Penicillin is the first line treatment. Alternative include clindamycin for allergy. Complications include recurrence and the chronic lymphadenopathy and the systemic prevention disease. Elevation of the limb is crucial in managing the lower limb erysipelas.